The following podcast is part of a certified educational activity titled A New Script for SCD Care, Guidance on Patient-Centric Treatment Decisions with Innovative Therapeutics. Access the entire activity and complete the post-test at peerview.com/EEY860. Downloadable slides and practice aids are also available.
Good morning, everyone, and thank you for joining us for today's program. We have a very nice program planned for you today, and the topic is a new script for sickle cell disease care, guidance on patient-centric treatment decisions with innovative therapeutics. Today's panelists are myself and Dr. Ford L. Rossi, and I'm from UT Health, is from Emory University. So sickle cell disease affects approximately 100,000 Americans, and it occurs among 1 of every 365 Black or African American births. Also in 1 of every 16,300 Hispanic American births, and about 1 in 13 Black or African American babies is born with sickle cell trait. Because it predominantly affects racial and ethnic minorities, we know that there's disparity in healthcare access and quality of care. So sickle cell disease is an inherited red blood cell disorder of the blood cell, just as I stated. That's when in deoxygenated condition or under stress, maybe patients are dehydrated, or at high altitude, the red blood cells can sickle. And when the red blood cells sickle, they are very fragile, rigid, non-deformable, and cannot pass very freely through the very small blood vessels. And they break down very easily. This results in hemolysis, and chronic hemolysis will lead to chronic anemia. And also those cells get stuck in very tiny blood vessels, and this results in vaso-occlusion. The end result will be multi-organ damage and severe, unpredictable episodes of pain. These are the complications of sickle cell disease and many more. Virtually anywhere where there are red blood cells and where there is a flow of blood, there can be complications. As you can see on this slide, it affects the eyes, lungs, heart, liver, the genital urinary system, including the kidneys, can cause severe pain, can affect the bone, by causing avascular necrosis, and bone infarct can affect skin by causing ulcers. There are different genotypes that have been described, and this can cause variety of sickling severity. We know that the sickle cell trait individuals, they're the ones that are carriers of sickle cell gene. So they're not affected, and when we do the hemoglobin electrophoresis, normally we see that they have more A than S. Sometimes under extreme stress, and when they're dehydrated and under exertion, they can have exertional sickling. People with hemoglobin SS and sickle beta null, they tend to have marked disease. And you can see that the hemoglobin typically range between 6 and 9. Also, these are the ones that have more complications, acute and chronic complications, than the others. The individuals with hemoglobin SC and sickle beta plus, they tend to have mild to moderate severe disease. And as you can see there, the hemoglobin can range anywhere from 9 to normal levels. Those with hemoglobin S and hereditary persistence of fetal hemoglobin, they tend to be asymptomatic unless they're under extreme stressors. And that is why with gene therapy, sometimes, with gene therapy, this can be curative because we increase fetal hemoglobin in these patients in one of the methods that I will describe later. So this slide shows the clinical burden of vaso-occlusive events that patients tend to have acute episodes of pain. Again, these are unpredictable episodes, and they can be very severe to the extent to bringing them to the emergency department and getting hospitalized for days. It is somatic in nature, and the individuals that are affected have typical anatomic distribution and tend to affect multiple sites. Certain sites can be symmetric in nature. We know that it has interpatient variation in frequency, even among the most severely affected ones. If the same people, different people have hemoglobin SS, some people can be coming in to the hospital 3 times, 4 times a year with vaso-occlusive episodes, and the other ones coming in after years of not being affected with VOE. It varies during different periods of time. So after a while of being VOE-free for years, certain patients will start coming in multiple times a year. It is responsible for vast majority of healthcare encounters, more than 90% of hospitalizations. This shows that VOE episodes contribute to sickle cell disease-related healthcare costs. As you can see on this slide, on the left, the total annual cost is on the y-axis and the VOE per year on the x-axis. And I will highlight the patient with 4 to 6 episodes per year that they tend to, at least this literature, this article showed that their annual cost is about $73,000. And for the people that have VOE of more than 10, $177,000 per year. And when you look at the lifetime cost for someone who has an average of more than 2 and about 2.7 per year, at age 40, they're already spending about $3 million in lifetime cost. And by age 60, this can range between 4.8 and 5.9 million. So we know that patients with sickle cell disease with recurrent VOEs experience a substantial economic burden that is driven by inpatient costs and frequent VOE. So, this slide outlines the unmet needs in sickle cell disease. We know that we need improved access to care, especially to adult providers. And there's need for better transition of care, more treatments to prevent and manage complications, alternatives to transfusion for stroke prevention, because people do get tired of getting transfused, every month to every 6 weeks if they're getting exchange transfusions. And we also need safer and more universally accessible curative options. We do need new agents to target downstream effects of sickling, and there's need for just better care delivery globally. There's need for increased access to quality expert care around the globe. Also, we want a collaborative care of sickle cell disease individuals for the care to be optimized and for better clinical outcome. We know that the patients and their families should participate, they must be informed, and they should be engaged in their care. In addition to that, the healthcare professionals should be well trained, and they should be capable of providing good care to individuals with sickle cell disease. And the community should be supportive of the individuals affected with sickle cell. These are SCD AA resources that are available to help your patients. including community health worker network, peer-to-peer mentoring, newborn screening, follow-up services. You can see the SCD resources also include webinar, research updates, clinical trial finders, pediatric to adult healthcare transition family toolkit, and talking with doctors. Our goals for today are outlined here: to improve your understanding of sickle cell disease burden and unmet medical needs, enhance your knowledge of evidence supporting newer and emerging therapeutics with clinical applications in sickle cell disease, equip you with the skills you need to develop personalized treatment plans using modern therapeutics, and provide guidance on addressing practical aspects of therapy delivery in sickle cell disease setting. So I'm going to be talking about the progress in sickle cell disease from disease-modifying agents to gene therapy. I'll start with a case of an individual. Michelle is a 20-year-old adult patient with sickle cell disease. And she was previously treated with crizanlizumab and L-glutamine with suboptimal responses. And she was started on hydroxyurea. Hemoglobin at baseline was noted to be about 8 grams per deciliter. And she had 4 vaso-occlusive episodes in the last 12 months. And 1 was managed at home, the rest at the emergency room. Currently, she had been on hydroxyurea at maximum tolerated dose, and she was compliant with the dosing. She's concerned about receiving VOE episodes and asked about other treatment options. So, Dr. Ford, how typical is this patient's presentation?
This is quite typical, in fact, of our patient population that we provide care for. This is a scenario that's fairly commonly seen, and yes, you're always at this crossroad. What do you do? How do you approach what's going on here? That's all I can say.
Yes, and I do agree that, yes, some patients, they do not respond to combination therapy even when they're on crizanlizumab and L-glutamine together. And some individuals do respond, but some don't. And what do we do next for those that don't respond? Although, with limited options of FDA-approved therapeutics, it is difficult for providers taking care of individuals with sickle cell to select and guide our patients. The other question is, does our experience with disease-modifying therapy reflect current clinical expectations?
This is not an uncommon situation with the current clinical treatments that we have, crizanlizumab, L-glutamine, and hydroxyurea, that you may have patients who still do not have a response to these medications. We always educate and make sure that our patients are partners in the therapy choice, meaning they know why they're on this therapy protocol or cascade, and how they should take the medication, keep their appointments, so we can get improvement in their care from such therapies. But that's not something uncommon. And we know that not all therapies fit all our patients, so yeah.
Thank you. Assuming that this patient is interested in exploring other modalities, how would you initiate a conversation on next steps, and what options would you recommend?
That's an excellent question. In fact, this is very common in practice. What I preach is engaging the patient and their family members about the latest of what we have in clinical trials and drug development and gene therapy as well. So part of the process is always keeping our patient educated and understanding of what's in discovery, what's going on, different mechanisms of targeting to help improve with the sickle cell event control. The big thing here is obviously gene therapy has recently been approved, but that is not readily available. But that's something I've been discussing with my patients. The other options in the meantime that we have is we have a lot of robust drug discovery. We have great partnership with the pharmaceutical industry to develop new therapeutics, new targeted pathways to help with our sickle cell care. And that's something I always explore with our patients. So having a full rounded approach of what's available, what's in the pipeline is always good. And I think that's a recommendation I have with that's a discussion to have with every single patient, family member, advocate to continue pushing the pipeline.
Yes, I do the same. I usually introduce clinical trials to individuals with sickle cell quite early. I give them options. Of course, I always start everyone with hydroxyurea. It's still the standard of therapy. But after that, we will talk depending on what's going on with them. I look at the lab. I look at what's going on in terms of VOE, and then decide, together with them, give them the literature, give them what options are available in clinical trial, and then talk about also that gene therapy has been approved and what are the benefits and the possible risk of taking that route. And also we can mention about stem cell transplant option if that patient has had major complications in the past. Thank you for that. We'll move on. So I will move on to modern therapy for sickle cell disease and overview. These are the milestones in sickle cell disease. From 1977 to 93, there's cooperative study of sickle cell disease. And then 1986, prophylactic penicillin study. 1992 to 2009, multi-center study of hydroxyurea. And then the stop trials in 1998 and 2005. 2011 baby hug, 2016 Twitch study, and sustained study, and that's phase 2 crizanlizumab study in 2017. And then in 2017, L-glutamine was approved. In 2019, crizanlizumab and voxelotor were approved by the FDA. And then in 2023, 2 gene therapies were approved by the FDA. And lovo-cel was approved for the treatment of sickle cell disease in patients that are at least 12 years of age and older with recurrent VOEs. And exa-cel approved for treatment of patients that are also 12 years and older with sickle cell disease and a history of VOEs. In 2024 to 25, currently, we know that we are working in clinical trials with pyruvate kinase activators and other novel strategies. And we're very excited about this. So now, just to review, we have some disease-modifying therapeutics. The medications there are hydroxyurea, which was approved in the United States in 1998, L-glutamine, crizanlizumab. Voxelotor was recently voluntarily withdrew by Pfizer. And then we also have transfusion, which is a non-medication disease-modifying therapy. We have curative therapies, stem cell transplant, and gene therapy is also quite transformational and we believe can be curative also. We have the general medical care. We take care of the patient holistically. We make sure they're up to date on the vaccination, annual eye exam, good nutrition, control the blood pressure, manage acute and chronic pain, and also screen and manage for acute and chronic complications from sickle cell. And just to compare hydroxyurea with L-glutamine, hydroxyurea is approved for all ages from age 9 months and older. And then L-glutamine 5 years or older. L-glutamine come in oral powder form that can be added to food or beverages twice daily. And hydroxyurea, you can take it once daily unless it's more than 2 grams a day. And then monitoring for hydroxyurea, we monitor the blood count while titrating the dose. And L-glutamine doesn't need any major monitoring. We know that we now have 25 years of safety data on hydroxyurea, and we know that it improved life expectancy, reduced acute pain episodes, and reduced vaso-occlusive complications, including acute chest and stroke, and reduced transfusion requirement. And on L-glutamine, the study that got it approved showed that it reduced acute pain episodes and can be combined with hydroxyurea. It has good safety profile. The caveat with hydroxyurea is are the side effects that some individuals face, like hair loss, GI symptoms, and when people are planning to conceive, we counsel them about being cautious of taking hydroxyurea. Although nowadays we know that if someone taking hydroxyurea who is pregnant is doing poorly, we can tell them to restart taking hydroxyurea, but we counsel them on the risk benefit of doing so. And then L-glutamine we tell people not to take over the counter and to take the pharmaceutical grade. And I will not talk about voxelotor since it's been withdrawn from the market, but crizanlizumab is approved for 16 years and older, and it's IV once a month maintenance after the bolus, after the initial loading dose. And then we know that it can reduce acute pain, can be combined with other therapies, good choice for severe and frequent pain episodes, people that are having that, and good option for people who do not like oral options. And it requires good IV access and hospital infusion. Some people sometimes have infusion reactions, and when they have that, it doesn't have to keep occurring, so they can be re-challenged with it, and can cause some other side effects as listed there. And the curative therapies, I will talk about a little more: stem cell transplant and gene therapy. So this publication showed basically lump up some of the stem cell transplants in both adult and pediatric population. And it had about more than 2,800 patients. And it showed that the overall survivor for all patients was very good, 96%. In pediatric, 97%, and adult, 98%. The disease-free survivor was also good, 90% and 91%. Acute graft-versus-host disease and chronic graft-versus-host disease were actually more in pediatric than adult. And also the non-relapse mortality was noted in the pediatric population, and graft failure outlined there. And the donor type are listed here: the sibling-matched donor, unrelated donor, umbilical cord, or haploidentical. And long-term risk also outlined here: graft-versus-host disease, which we need to counsel people that are considering this option on, and infertility risk, and also possibly secondary malignancy, because they're exposed to chemotherapy and other conditioning regimen that can cause this. And already, people with sickle cell disease, we believe that their bone marrow infrastructure has some damages already, and they're more prone to developing secondary malignancies sometimes. And so Michelle kind of consulted and wanted to possibly talk more about gene therapy. How would you plan to counsel patients on the curative potential ability of gene therapy to address the VOE?
Yeah, this is a great question again, because gene therapy, which we'll talk about in a few slides, is one of the latest approvals in our arsenal of therapy for sickle cell. The first thing that we need to discuss with Michelle is the understanding of what the gene therapy is. It's not a simple infusion and you're done. There's a process for this. There's establishing care and going to see one of our transplant colleagues that will proceed with explaining further about what the gene therapy is. There's definitely a need to ask about the psychosocial situation for Michelle, who will be a provider and aid during the process. There's a lot of preparatory work that needs to happen. Imaging needs to be done, evaluations, and close follow-ups before and after the gene therapy is considered. And then again, the biggest hint in discussion here is the gene therapy that we have recently approved have not been approved for quite a long time. So we do not have a long-term safety profile for such approved gene therapies. And that's important to bring out.
Yeah, and those are great points. We really have to let individuals considering this option know all this, that, the risk benefits also. We mentioned that they're going to get conditioning, regimen, busulfan, and this can sometimes cause other things.
I can say from a patient perspective,
okay,
the preparatory regimens, the busulfan based regimen, folks have not heard about it. They do not know that that's involved in gene therapy, and that's chemotherapy that's going to be given, and that will have its own effects and risk factors later on, possibly. So that's always to be determined as we progress with such therapies and have more and more safety data.
Yes, okay, very good. And what are the safety, well, you've kind of mentioned about this, so I think we've answered our questions, so that's good. All right, thank you. So I'm going to talk a little bit about the gene therapies that were just approved in, just last year, December. exa-cel consists of autologous CD34 hematopoietic stem and progenitor cells that are modified using non-viral ex vivo CRISPR-Cas9 technology. And basically, it's worked on the BCL11A, which is the erythroid lineage, is where it's worked on. And it's a very neat technology, and basically it will upregulate the production of fetal hemoglobin. And as I mentioned earlier, when we have the non-sickle hemoglobin and increase that, that can really help the patient feel much better in terms of VOE and all the other complications. And that's, if we get to a particular level, and if it's pancellular, if it's well spread out in the cells, then it can be very useful for the patient, and it can be curative. And that's basically what exa-cel did. And you can see here, these are the procedures that will happen with the gene therapy. Patient will come in for screening, and then their stem cells will be collected after they're given certain products. They will be given granulocyte colony stimulating factor and pleuroxephrol. And after that, the cells in their bone marrow will kind of go up, and that's what we want. The stem cells will increase, and then the cells get prepared. It gets edited, by the very nice technology. And then afterwards, the cells will get treated, frozen out. The cells get returned for use when the patient is almost ready for treatment. The patient will be treated, just as he mentioned, with conditioning chemotherapy, busulfan. And this, we really have to make sure that people that are considering gene therapy understand that. So after busulfan treatment, the cells that were collected and returned to the site will be infused back to the patient. And then we will wait for the patient to engraft. That means the cells will start coming back up in their body. We want the neutrophils, the infection-fighting white blood cells, to really come up in their body, and then they get discharged. And they will follow up later on. Of course, there will be very close follow-up. They will not just come back 2 years later. They have to follow up many more times, you know, every few weeks, and then monthly, and so on and so forth. But this slide here just outlined the study that was done that got this approved. And looking at the patients that were treated with exa-cel, there was a New England Journal of Medicine article that was just published in April of this year that showed that after a good follow-up of maybe an average of 1 year follow-up on 29 out of the 30 patients, they were VOE-free. So that was quite significant. One participant had a VOE in the setting of parvovirus. So 1 out of 30 had vaso-occlusive, episode, pain episode, out of the 30 patients. So this was really very nice to know. And it was a median follow-up of about 22 months. And before screening, the participants must have at least two per year of VOE, or 4 total in the previous 24 months before they even enter the study and get exa-cel. All this diamond blue colored were their VOE events before they got infused with exa-cel. And afterwards, you can see that majority of them did not have any VOE event. The side effects or adverse events of the exa-cel are outlined here, grade 3 to 4. So those that had the ones that are considered advanced adverse events. Stomatitis, meaning inflammation of the mucous membrane in the mouth or GI system, were about 55% of them. And those that had fever when they were very neutropenic were 48%. And you can see other adverse events as outlined. Low blood counts are really expected in majority of the patients undergoing any autologous stem cell transplants, and other adverse events as outlined on this slide. Now I will talk about lovo-cel, the other gene therapy that was also approved last year, December. So this is also using a cell therapy, autologous stem cell transplant. And this one, though, used a lentivirus vector, which then kind of encode a modified beta-globin gene to produce anti-sickling hemoglobin. So it mimics hemoglobin A production. So the modified hemoglobin it's really very similar to hemoglobin A. And the process is very similar, except that the lentivirus transduction happen with this procedure. So stem cells will get collected, and then there will be selection of the stem cells. Transduction with the lentivirus will happen. There will be quality testing of the cells, and then the cells will get infused back after conditioning regimen. So the individuals, the participants, will get busulfan again as the conditioning regimen. They get chemotherapy before they get the infusion back to them. And then we'll wait for engraftment of the cells, meaning they need to start producing their cells back before we release them from the hospital. And This slide basically showed that lovo-cel was also very highly effective. It showed that the participants had sustained production of the modified hemoglobin, and it led to reduced hemolysis and complete resolution of severe VOE. After about 60-month follow-up, 88% of patients, that was 30 out of 34 of them, had complete resolution of all VOEs during the 6 to 18-month assessment period. And 10 out of 10 of adolescent patients had complete resolution of VOE. And you can see the same here. The dots, the red dots, were their VOEs before they got the lovo-cel infusion, and afterwards, majority of them were without any event. The safety profile also was quite consistent with what we see with stem cell transplant and myeloablative conditioning with chemotherapy. 69% with stomatitis. Those with cytopenias were about half of the patients with thrombocytopenia and neutropenia. And febrile neutropenia occur in about 43% of the patients. And you can see other adverse events as mentioned on this slide. And it's very important to note that when participants or individuals get busulfan chemotherapy, we usually have to cancel them on fertility because majority of them will not be able to conceive naturally after that. So it's very important that they have fertility preservation, which can be very costly for an individual that is very young, because yearly they have to pay a certain fee to keep, whether the egg preservation or sperm preservation. So it's something major for certain individuals. So the moment we mention fertility, for some individuals, then they will not go forward. So these are the important considerations regarding gene therapy. It is a complicated procedure and logistically challenging administration, as I show in those slides. Infertility risk due to pre-therapy conditioning. The cost factor, it's quite expensive. The average price is between 1.5 to about 3 million per patient. And then, we're still awaiting the long-term safety profile. However, I think the good news that we heard is that the U.S. Department of Health and Human Services made an announcement that sickle cell disease will be the first focus of cell and gene therapy access model, in the coming year. So that's a good thing. All right, I'll turn it over to Dr. L-Rossi.
Thank you, Dr. Adu. I'm going to start off with a clinical consult, a patient with VOEs and anemia, to set the stage for what I want to discuss later. So this is Mark. He is a 33-year-old patient with sickle cell disease and a history of around 5 sickle cell crises a year. He is on hydroxyurea and has been on this for quite a long time. Lives in a remote area leading to transportation issues. Crizanlizumab was discussed as an option, but not truly an option due to these transportation issues. In addition, he was hesitant to start the treatment because of the height of the COVID-19 pandemic. The current status we have right now is the patient is taking 1,500 milligrams with a decent increase in fetal hemoglobin to 15%. He is still experiencing pain events, as you can see. Hemoglobin is at 8 grams per deciliter, MCV is 120. Hospitalizations or acute care visits every 2 to 3 months, and possibly a discussion for a clinical trial is underway. The discussion points here with Dr. Odu is, what aspects of this case would make you pause before recommending a disease-modifying agent versus gene therapy versus a trial of a novel mechanism of action drug?
Well, it looks like the patient has some transportation issues, so kind of psychosocial issues that we have to talk about before we start anything like gene therapy, because for that, they will need multiple trips and they have to really be adherent to the plan of care. Now, in terms of disease-modifying therapies on clinical trial, majority of the time, the good news is that with the transportation issue, most of the sponsors for the clinical trials, they do provide transportation means for the participants from any distance, even if they have to fly or go several miles away, from wherever they're coming from. So I would definitely, discuss clinical trial option with this patient.
Second question, does the baseline hemoglobin count inform our treatment choices?
Yeah, the hemoglobin of 8, it looks like, we can still do better. We can increase that hemoglobin and probably reduce his hemolysis. I don't see his hemolysis panel, but I imagine that it's still hemolyzing at a high rate. And the novel therapies that I believe you will talk about, the pyruvate kinase activators, they're very good with doing this. They do it very well. So that would be a treatment option.
Excellent. And then I think the last question, how does the transportation challenge complicate overall management? I think you hinted at that, of course. In addition, some clinical trials do offer overnight stay for really remote patients or candidates who live quite a distance. So that's an excellent option. Great. All right. Another question is, are PKR activators likely to address complications like anemia and improve hemoglobin levels, reduce hemolysis? I can say I will show you this in the next few slides based on the early phase of the trials that we have ongoing. And what about other aspects of sickle cell disease like pain and sickling? Also, the next coming slides will hint and show that, hopefully. So what I will be talking about are the new mechanisms in development against sickle cell disease. And the next steps that we have here in this slide are just a brief overview of a huge panel of different therapeutic agents being explored and underway. At first, we have the PKR activation, and we have 2 main molecules being investigated, etavopivat and mitapivat, and I will talk about them in detail, and the clinical trials ongoing. We also have epigenetic strategies in the example of oral decitabine tetrahydrouridine, which I will discuss as well, in addition to other hemoglobin F inducers and possibly complement inhibitors, which I will not shed light on today. Impaired RBC health is an opportunity for a target in sickle cell disease. And what we mean by impaired RBC health is the fact that sickle red blood cells are known to have high levels of 2,3-DPG, which decreases the strength of binding between hemoglobin S and oxygen and increases the chance of polymerization and sickling. In addition, we know that the sickle red blood cells have low levels of ATP, which makes it harder for the RBC to maintain deformability and repair damage to the cell membrane. And in the example of etavopivat, which is a pyruvate kinase activator with a multimodal mechanism of action, we know etavopivat, by activating PKR, will lead to 2 specific effects, which is the increase of ATP that helps increase red blood cell membrane repair, and a decrease in hemoglobin S polymerization by decreasing the level of 2,3-DPG. And the hypothesis that we have for etavopivat is the pyruvate kinase activation will, like I said, decrease the 2,3-DPG and increase the ATP, and by doing so, make the sickle red blood cell healthier and hopefully less sickle to have an effect of an increase in hemoglobin and decrease in vasoocclusion. Similarly, pyruvate kinase activation with mitapivat has a significant role on both 2,3-DPG and ATP. Mitapivat, again, is binding and activating pyruvate kinase, which will lead to higher levels of ATP, and at the same time decreasing the 2,3-DPG level, which will help with the red cell health, the sickle red cell health here, in leading to less sickling, less hemolysis, a higher hemoglobin, and less pain events. We also have another mechanism underway in clinical trials, which is the depletion of DNMT1. This is a mechanism that looks at reactivating fetal hemoglobin And the rationale for it is a DNMT1 inhibitor reduces the activity of this enzyme, and by doing so removes methylation, which is a marker and a stopping mechanism for fetal hemoglobin production. And so as you can see here, by having this DNMT1 inhibitor bind to its target, you'll have less methylation and higher fetal hemoglobin subsequently that will help reduce the amount of sickling in a patient with sickle cell disease. This agent, NDEC, or decitabine tetrahydrouridine, the theory is it will increase fetal hemoglobin, and by doing so will reduce hemoglobin S polymerization. So what we know is in the bone marrow, decitabine will deplete the DNMT1, and thus reactivating fetal hemoglobin. We also know that the combination with the cytidine deaminase will reduce the effect of decitabine in the GI tract, thus limiting its oral bioavailability. That's why the tetrahydrouridine part is added to the treatment to prolong the decitabine function. This is currently being explored in an ongoing clinical trial called the ASCENT-1 trial, which is in phase 2 right now. The study involves an interesting approach where hydroxyurea is used as a stratifying mechanism. It's splitting into hydroxyurea non-eligible patients and hydroxyurea active patients. In the arm where hydroxyurea is non-eligible, patients are randomized between a placebo once-weekly dose with NDEC, NDEC twice weekly, and a full placebo arm. And for the hydroxyurea active treatment, the interesting part is the patients who are enrolled will go through a washout period of hydroxyurea so that they can assess the NDEC treatment effect, either once weekly or twice weekly, and compare it to hydroxyurea, which is going to be on board as an open label to see the effect of NDEC versus hydroxyurea immediately. This study is underway, and we'll see soon some more information and details about this phase 2. Going back to Mark, our patient who is preparing for a possible clinical trial enrollment. So the current status is the patient is in the consent process for the clinical trial. Him and the healthcare team have had a detailed discussion on specifically the pyruvate kinase mechanism, the protocol involved, and the possible side effect profile. And the consent process is not something immediate. It really needs multiple visits, multiple reviews. This is really furthering the understanding of what a trial involves and what the mechanism is involved, and includes additional possible review of the medication and the trial at home before any consent can occur. The discussion point here for Dr. Adowu is, given the upcoming trials of PKR therapy, what are dosing considerations that have emerged from early clinical experience that will inform this patient's care? And I'll add the second question. How can clinicians prepare for safety considerations with PKR activators?
So if we're talking about the Rise Up study, for example, the dose that we will choose. So after doing a phase 2 study, we look at the better dose out of the doses that were compared with one another, and we usually choose the one that works best. And for Rise Up, we chose the higher dose, which was the 100 milligram BID.
And I will show that.
And you will show.
Yes.
Okay, you say you will show. And then how can clinicians prepare for safety considerations with PKR activators?
Meaning this is a new drug, new
Mm-hmm.
therapy. We don't know what it can, but what would you do in this situation knowing that's a clinical trial? What would you inform the patient of?
Yeah, basically, we just need to, look at the early data because, for phase 1 is probably already happened. We look at whatsoever the first few, complained of, and we always let them know. We're very transparent with any clinical trial. We always, if anyone enters any clinical trial and they complain about anything, the data is well captured. I tell people that there are very good regulatory boards over clinical trials nowadays so that they can really trust the process, that we will really inform them about everything going on. So, but usually I let them know if there are, people complaining about headaches, GI issues, I let them know that so they're well informed And I let them know that they can stop the trial at any time. But they're also well informed about the benefits of the therapy and why we are talking about starting them on it.
Exactly. I mean, the enrollment on a clinical trial, we really have to acknowledge every possible adverse event that can happen. And based on that, like you said, specific boards exist to deem, is this related or not related to the medication being in trial. Excellent, thank you. All right, and then the last question we have here, what will be likely the role of PKR activators in the management of sickle cell disease? I will show this in the next few slides, and exactly, hopefully, this will be a good take-home message. So what we have with the initial evidence of specifically, for example here, etavopivat, is we can tell from early studies that it led specifically to the decrease of the 2,3-DPG agent and increase in ATP, as you can see here. And this is what we had hypothesized in the mechanism of action with pyruvate kinase activation. In fact, in the SCD setting, etavopivat in the open label arm of the phase 1 study did show that during the course of the study, there was a drop, significant drop in the 2,3-DPG levels, and once at the end of therapy, you can see the 2,3-DPG levels go up. And same thing for ATP. You can see ATP levels increasing during the course of therapy, and once end of therapy happens, the ATP levels come down. And this translated to about 73% of the patients with sickle cell disease having an increase in hemoglobin by at least 1 gram during the therapy phase. The effect of etavopivat on hemoglobin responders was seen all through the different arms evaluated in the phase 1. So at the 300 milligram arm, the 600 milligram arm, and even the open label 400 milligram arm. And you can see here 1.4, 1.4, 1.6 grams per deciliter increase noted in this early study. Next steps with etavopivat is the ongoing HIBISCUS clinical trial, or HIBISCUS-1. This is a phase 2/3 study to investigate the safety and the efficacy of etavopivat in patients with sickle cell disease. Like I said, recruitment is ongoing, and I believe they are at about 369 patients out of 440 total. The dose determination group was the early phase of the study, which is this arm here, and that has concluded, and it's been decided that the 400 milligram arm was the effective dose, and that's what the second part of the study, or the remaining phase 3 part of the study, is ongoing for. It's great to have also an open label extension, which means after the study concludes, after a total of 52 weeks, patients who were involved in the clinical trial have the option of staying on the medication for another extension of 1 year. The criteria for enrollment stratifies the patients based on the number of vaso-occlusive events. So you have one population between 2 and 3 vaso-occlusive events, and another population between 4 and 10, and that has been recently increased to up to 15 vaso-occlusive events. Hydroxyurea concomitant use or prior use is allowed and not a consideration for exclusion. However, newer therapies are a consideration. And in fact, there is underlying stratification for also the hydroxyurea effects. The main eligibility criteria for the study is having, like I said, at least 2 episodes of vaso-occlusive crisis and having a hemoglobin between 5.5 and less than 10 during the screening phase of the study. HIBISCUS-KIDS is the counterpart of this study for the pediatric population. This is a single-arm, open-label, phase 1/2 PK and safety study. This is looking at patients aged 12 to 18 with sickle cell disease and looking at a total of 50 patients. Similar profile, but the difference here is it's not randomized. It's an open label etavopivat 400 milligrams oral daily medication for a 24-week treatment period, followed by a 72-week extension for further evaluation. Mitapivat is the agent also involved in another clinical trial, the RISE UP phase 2/3 clinical trial. RISE UP is a global phase 2/3 double-blind randomized placebo-controlled trial evaluating the efficacy and safety of mitapivat in sickle cell disease. This study has also a phase 2 portion, which is a dose finding evaluating 2 doses of mitapivat, the 50 milligram twice a day and the 100 milligram twice a day versus placebo. And the decision was set almost a year ago to proceed with the 100 milligram twice a day dose for the continuation of the phase 3. After the initial phase 3, then you have a continuation of the study on the 100 milligram twice a day arm with the option of going on an open label extension period of up to 216 weeks. And then the primary endpoint here again is hemoglobin response, defined as an increase in hemoglobin by more than 1 gram per deciliter increase in average hemoglobin over a 10 to 12 week period compared to baseline, along with safety considerations. From Rise Up, mitapivat was found to induce higher hemoglobin response compared with placebo in patients with sickle cell disease. And showing you this waterfall plot that shows mitapivat 50 milligrams twice a day in orange, mitapivat 100 milligrams twice a day in blue, and then in green, the placebo. And as you can see, patients on mitapivat 50 or 100 had a significant increase in hemoglobin during their course of enrollment on the study compared to placebo. And that translated to a difference in hemoglobin responders in about 46 and 50% of patients involved, and significant increase between 42 and 46% for the patients on the medication compared to placebo, which is very significant. These improvements in hemoglobin levels were also observed with both doses later in the study, once the conclusion of the phase 2 part of the study. As you can see here, 26 patients on each arm versus placebo. And you can see the average change from baseline hemoglobin was 1.1, 1.13 versus really not much of change for the placebo arm. In addition, improvement in markers of hemolysis and erythropoiesis were observed in both mitapivat arms versus placebo. And in fact, the magnitude of improvement was generally larger in the 100 milligram twice a day arm, and that's the choice that was made for the continuation of the study. In addition, there were reductions in the sickle cell vaso-occlusive events observed in both the mitapivat 50 and the 100 milligram arm. And as you can see here, the annualized rate of sickle cell pain crisis in both 50 and more significantly the 100 quite reduced compared to placebo. And the rate reduction was 51% for the 50 milligram dose, 70% for the 100 milligram dose. In fact, the whole study concluded to enrollment just last week, which is amazing. So we're quite excited to see the data that will come out from Rise Up, given its amazing effects on increase in hemoglobin and reduction of pain events. All right. I will shift to preparing for dosing and safety considerations with PKR activators. And the experience so far with what I've shown you with PKR activators is very encouraging and very promising. We know this is oral therapy. Initial dose started based on the clinical trial determination, but now we have determined exact doses for the phase 3 arms of the study. 100 milligram twice a day for Rise Up for mitapivat, and 400 milligrams daily for etavopivat with the HIBISCUS-1 study. The question here is, what are the expectations for symptom management that will arise from such agents, knowing that we've had some experience with the early phase studies and phase 2 concluding, and knowing that we do see an increase in hemoglobin. So the things to monitor and look for, which are typical of such studies, are looking for headache events or occurrence, as seen in the early phase studies, possible GI side effects being mitigated, and making sure that tolerance to the medication happens from the beginning. Monitoring for liver function tests, that's something and piece and part of every single clinical trial that we do, knowing that sickle cell disease can contribute and add to the effect on the liver, and close follow-up for the rates of sickle cell crisis that may occur for patients on these medications. So with etavopivat, it was well tolerated in the SCD setting with a safety profile consistent with PKR activation. So what we have here is data from the early phase study where I can tell you that the VOE that was most common treatment-related adverse event. It occurred in about 37, 38, 46% of patients in different arms of the phase 1 study, which was quite seen all through the different arms here. And in RISE UP, which we have the phase 2 data as well for, mitapivat safety was consistent with previous reports from the sickle cell disease setting. Again, in the 2 different treatment doses versus placebo, headache was the most common occurring adverse event, as you can see in 23 and 25% of patients, followed by arthralgia, and then pain, which can happen in the setting of sickle cell crisis, pain and pain in the extremity as well. And you can see the rest of the effects, adverse events reported. All right, so in the symposium summary and take-homes, Dr. Adu.
So on my side, the summary from the current standards in sickle cell disease. Sickle cell disease is a disabling disease that affects multiple organ systems. Treatment for patients with sickle cell disease should be individualized and comprehensive. Stem cell transplant and gene therapy are treatments with curative and transformative potentials. And approvers of additional sickle cell disease modifying therapies are major unmet needs.
Excellent. And then for future of sickle cell disease arsenal of therapy, a big thing is the withdrawal of voxelotor. We will discuss this further in the question-answer session, but this definitely necessitates the need to have more therapeutic targets. The current clinical trials underway that I discussed are very exciting, and the pyruvate kinase pathway has promise, and it's an example of oral agents in development that hopefully we can have concluding data on these major trials and may be added to the treatments options that we have. We know that they may address anemia, hemolysis, and sickling from the data so far, and I think this is really great to offer for our patients. Additional options are still being explored and tested, and we don't have the time to go through what else is happening, but the participation of our patient population in clinical trials is extremely warranted to further the understanding of the different targets involved and hopefully have more treatments pending, more also gene therapy safety data.
For the Q&A, we will start with some of the questions that have come in. One of the questions said, is hemoglobin S still a target for red blood cell exchange, and how does using a PKR activator affect that?
Yes, thank you for that question. Hemoglobin S remains a target for RBC exchange, and for the PKR activator clinical trials that I discussed, an exclusion is being on chronic transfusion therapy. That said, there are undergoing and ongoing clinical trials looking at transfused sickle cell patients with PKR activators as well as thalassemia transfusion therapy studies for PKR activators. So we'll find and get more information about that.
And the second question, how different is the side effect profile with PKR activators compared with P-selectin and hemoglobin S agents?
Yes, as I showed from the early phase studies that we've seen, the side effect profile seems very well tolerated. The most common events reported were related to sickle cell events. Headache is a consideration observed across the category, and that's something to watch for when you start such therapy. But overall, very well tolerated, and a side effect profile that seems to be safe so far, but we'll get more and more information from the subsequent phase 3 studies ongoing.
Very good. I'll take the third one. What is the timing for referring patients to gene therapy? In other words, what kind of advanced planning is necessary before encouraging a patient to pursue the option? So for gene therapy, after counseling the patients about the risk and benefits of taking this approach, if they do want to, go forward, we want to make sure that they have, the psychosocial support for going through an autologous stem cell transplant. They've made preparation for fertility preservation, and they're comfortable with, the possible adverse events, and the fact that there's no long-term follow-up, that we have up until maybe 7 years on the longest person that had gene therapy. So we have to take those into consideration. What type of patients that we would encourage to probably go forward if they're interested? Those are the ones that are severely affected, those that have had major complications to sickle cell that could be life-threatening, Of course, it's been approved for severe VOEs, as you've seen, because any severe VOE could have caused mortality to the person affected. So if they're interested and they're, good fit for it, then it is okay to go along, to go for it. And the next question is thoughts on how to increase access to new sickle cell disease therapies for undeserved or minority populations. I think we need to keep advocating for new therapies to be approved. It's, unfortunate that we only had 4 disease-modifying therapies in terms of medications, and now we have 3 that were FDA approved because 1 was withdrawn. So we need to keep advocating for, the regulatory organizations to approve more of these therapies, because this is a debilitating inherited blood disorder, and it's really shameful that it's been about a century long, longer than a century, and in the US we only have 3 disease-modifying therapies in terms of drugs. We need more targeted therapies. There's no question about that. So next question, looking ahead, do you think pyruvate kinase agent activators or others could be useful as a combination strategy to address a range of issues, anemia and VOEs?
Yes, the clinical trials ongoing do have a combination possibility with hydroxyurea. Patients are enrolled while being on a stable dose of hydroxyurea. So I see a potential, once we get the final phase 3 data analysis done, we'll see the effects of the combination. And hopefully we can see without the combination some effects as well. That will be helpful because, again, most of the therapies that we've had approved have happened in the majority of the patients on hydroxyurea, but we haven't seen effects of such therapies not on hydroxyurea, if that makes sense.
Yeah. Very good. And what is your suggestion for the recommended sequencing timing of therapies, including hydroxyurea, PKR activators, stem cell transplant, and gene therapy?
Obviously, hydroxyurea remains our key building block of medication that we start our patients on. And depending on the occurrence of events, whether it's anemia, vaso-occlusion, we are adding additional disease-modifying therapy. In the case that I described, I think a clinical trial with a pyruvate kinase activator makes sense given the patient remains quite anemic, despite being on an adequate dose of hydroxyurea. And I see this happening even before consideration for gene therapy because we still lack long-term safety data, and I know gene therapy is not readily available everywhere. Knowing that also access to the gene therapy for folks who may live quite far from a center that does that may be a rate-limiting factor too. So I advocate and I support going through the sequence of current approved therapies, possible therapeutic target investigation with a clinical trial, and then if we have great safety data from gene therapy and we can cure every single patient, I will not be against that. Yeah, that's our hope.
And I agree with that patients should go through, hydroxyurea as the standard therapy, and then we'll build on that. We can add pyruvate kinase activator, even though it's still in clinical trial, if they're candidates for that, unless, of course, many people, they are not comfortable with clinical trial, but if they are, it's probably the way to go for some. But for others also, because of the type of complications they've had in the past, are so severe that they really probably good
Sure.
candidates, and they're comfortable with the risk-benefits kind of ratio that the gene therapy is offering, and now that is approved. But I see many patients actually going towards the clinical trial, but a few others are also very much interested in gene therapy.
Yeah. The promise and the effect is amazing, in fact, that
Yeah.
we saw.
So the next question, is it now a one or other approach was stem cell transplant versus gene therapy? Would gene therapy completely replace stem cell transplant in the future? Only time will tell about this. As they are optimizing gene therapy, gene therapy safety profile so far looks great. Stem cell transplant, Dr. Kasim presented haploidentical stem cell transplant, his experience from the Centers of Excellence, last year at ASH. The data looked great. They're also optimizing that. So as they're optimizing those therapies, time will tell which one will be better for certain patients, and also the cost consideration. What are they able to afford? That's very significant, to look at. So we will just have to wait and see.
One thing to add regarding the stem cell therapy is with the 1503 STRIDE clinical trial protocol, the key rate limiting was the presence of match-related or unrelated donors to do such therapy. So that's why haploidentical may be the answer to that. But gene therapy, in a way, if you think about it, it's an autologous. It's your own cells. So that takes that rate-limiting step out of the picture. And yeah. But I agree with you. Time will tell.
Yeah. And the next question, in your opinion, is there a type of patient who might be the optimal candidate for gene therapy? Same question for a pyruvate kinase activator.
For a pyruvate kinase activator, in my opinion, any patient is a candidate for any therapy. You have to really work with your patient, with your family member, caregiver, and explore the different options. It's a shared decision-making process. It's never me deciding what, but we decide this as a team all together. The treatment options that exist are always shared and discussed, and some folks may have preference not to participate in a clinical trial, and I respect that. But definitely knowing what's out there, what is available, is always something that needs to be fully discussed with your patient, and that way, you don't have to select one or the other, but you have this discussion, and that's how you base it.
And to add to that, people I kind of encourage to go on pyruvate kinase activators. They're also the ones that have high hemolysis at steady state. Those anemic kind of phenotype patients, I believe they can really benefit from that. Because even some people, they don't really go in for VOEs as many times at all. But then they have high hemolysis at steady state. They come in, their bilirubin, indirect bilirubin is at 8 at steady state. And those are the ones sometimes that we actually see often by age 30, they have end organ, damages like end-stage kidney disease and all kind of stuff. So we do not want to be seeing that high hemolysis at steady state. We really want to target those. I think these agents are excellent to target those patients. So I typically will approach those patients, and if they're already optimized on hydroxyurea, I will say, I have another agent, it's in clinical trial. This is how it works, but this is why I think this will benefit you. And if they're interested, I will go, we will go for it. And the next question, what do you recommend for patients taking voxelotor now that it has been withdrawn? Thinking of someone who has had problems with hydroxyurea, but with pain episodes more or less in check with Vox. What is the next step for that type of patient?
I mean, this is an unfortunate thing, what happened, and we have to deal with it. I've dealt with it personally with several of my patients. And we discussed the options available. So we have 3 FDA-approved therapy. If the patient is on hydroxyurea and was on voxelotor and now they cannot take it, we'll consider the other 2 options if they fit their profile. Knowing that most of the patients were on voxelotor because of their anemia, because of more hemolysis, they may be more candidates for a possibility of a clinical trial with a PKR activator or other available trials that can be the case. That's also discussed with the respective patient, and we get to a conclusion. So we have a restricted, treatment profile, and we have to get by with what we have. But I think this is a great opportune moment to really say that we need our patients, our caregivers, our family members to understand the role clinical trials play in discovering more therapies. It's unfortunate what happened with voxelotor, but large enrollment of folks on clinical trials is extremely warranted and encouraged so that we can get true data, long-term data, and see the effects and not have missteps like we've had with voxelotor.
I agree. And that's what I am doing with some of my patients that were on voxelotor because they really needed that, reduction in hemolysis, and now, they don't really have any option unless, they are interested in clinical trials. So I actually open up the floor to, talking about what we have in clinical trial and what can help them. But I agree with you that it's unfortunate what happened with voxelotor, and we do need to advocate for more of the targeted disease-modifying therapies for sickle cell to be approved.
I see another question here. What are your strategies for helping patients from rural or low resource areas access newer therapies, clinical trials, et cetera?
Yeah. So patients in low resource areas, to access newer therapies, if they're interested in clinical trial and they're living maybe even at a distance from a center of excellence, sometimes, and a lot of times I would say, the sponsor for the clinical trial can actually help them with transportation back and forth if they're willing to do that. So they will be accommodated in accessing that type of care. In terms of disease-modifying therapies that are already FDA approved, it is difficult to tell. It will have to depend on their insurance plans, if they have that, if they live in the US. If they're in other countries and they do want to access the disease-modifying therapies that are already approved, it can be a little, challenging. It can be, to access unless, they have other means to do so through the kind of compassionate, program from the sponsor. The next question, how quick would you be to offer transplant or gene therapy for a patient transitioning out of young adult care into adult care? Does the degree of family support inform your recommendation? So someone transitioning, I will first have to understand and actually have a relationship with them to understand what their psychosocial support is like, what their medication adherence is like, how are they, what their disease state is like before we move forward about recommending such a treatment. Because as we mentioned, it's a complex treatment. It's really a lot that we have to discuss about, do they understand what the fertility implication is? We do not have probably long-term data yet, and they're young. So are they really interested? Would they still be happy about their decision 2, 3 years, 5 years later? So we have to make sure that they're able to understand the implication of their decision.
I agree.
Okay.
Yep. I think next, there's a question here. Please explain the role of a pediatrician in managing the disease.
So I'm not a pediatrician.
Neither am I,
But yes, I work very well with my pediatric colleagues. We have transition projects going on in Houston. So and we do engage each other. We do engage one another in discussion. We make sure that in terms of transition, that we have a warm hand of transition. For our adolescents, we give report. We meet bi-weekly to talk about adolescents who are, close to transitioning, and that's where we can learn more about that individual, how they are, how we can best take care of them and provide that optimal, individualized and comprehensive care to them, and that will really help both of us, both myself, the provider, and the patient and family, everybody.
I mean,
We're
they are
all
our partners,
and
yes,
the community.
absolutely.
Right?
So
yeah.
I have an interesting question that I saw down here that I'm going to bring up. Have you already transitioned patients off voxelotor? What do you recommend as the next step? I think we've discussed this already, but this is something that I've discussed, like I said, with a lot of my patients who were on voxelotor, and what I've recommended to them was what's out there, what's available, but at the same time, I encourage them to consider a possibility for a clinical trial, and I've seen great response and enthusiasm about that. So just more education, more encouragement, and hopefully we don't have to go through that again. So, all right.
And
anything?
Yeah, maybe one more.
Considering
the extent of care needed over a patient's life, do you ever consider re-exposure to an agent that's been previously used, assuming there was no major safety issue?
Yeah, I mean, that's an excellent question. If a patient, like your patient case, was previously on crizanlizumab or L-glutamine, but did not work, would you reconsider things? I don't see that as I see that as an option. You have to discuss that with the patient. Knowing that we only have 3 approved therapies, we have to recycle sometimes. So circumstances can change. Different things may attribute to maybe, for example, with oral glutamine, it's a powder that you have to consume twice a day. So if you did not take that every single day, maybe there was no benefit felt from that. That may be a consideration. With crizanlizumab, I still consider it for patients who have a lot of pain events while on hydroxyurea, and I give it more time. It's interesting that we have a subset of patients on crizanlizumab who have responded very nicely and have had significant reduction in pain events, but it's obvious it works for some, but not all. So definitely worth considering.
And I agree. I do actually consider re-challenging some patients, and especially if there are reasons why they stop using the disease-modifying therapy. For some, they stop using crizanlizumab because of transportation issues. If that's resolved, then we can restart that therapy. So depending on the reason why they stopped. If it just didn't work at all, if it wasn't effective, then there's no reason to restart. Thank you very much for joining us today.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is developed with our educational partner, Sickle Cell Disease Association of America, Incorporated. This activity is supported by independent educational grants from Agios Pharmaceuticals, Incorporated and Novo Nordisk Incorporated. To access all materials for this activity, visit peerview.com/EEY860.